Okay. So good morning, everyone. I just wanted to say thank you to everyone joining us today and for everyone tuning in later. My name is Brittany Badger. I'm currently one of the executives for Stigma Ends at CU, which is a student-led campaign functioning out of Carleton University with the goal of reducing the stigma surrounding substance use and substance use disorders. So I'm so lucky to be joined by my good friend and co-host Lauren today and the brilliant Dr. Chris Cavacuiti. I'm really excited for you guys to all hear about some of the incredible work Dr. Cavacuiti is doing and his approach to normalizing conversations surrounding substance use health. So I'm going to pass it over to Lauren to introduce herself, and then Dr. Cavacuiti, you can introduce yourself and get your presentation started.
Sounds great.
Hi, everyone. My name is Lauren. I am the internal team lead for Stigma Ends at CU here, and I'm really excited to be hosting this presentation with Brittany, and I'm really excited to hear what Chris Cavacuiti has to say. So on to you, Chris.
Thanks very much for the introduction. So hi, everyone. I'm Chris Cavacuiti. I'm the founder and CEO for the True North Addiction Medicine program. It's one of the hats that I wear. I also have founded an independent medical exam program that specifically focuses on people in safety-sensitive positions who may have issues with substances. Also the medical director for the PATH Ontario program, which stands for Prevention, Assessment and Treatment of Hepatitis. As some of the folks on this call may already know, hepatitis C is actually quite common amongst our patient population. Roughly 85% of all new cases of hepatitis C in Canada are related to intravenous drug use. So we see that fairly commonly in our patient population. And then I'm also an assistant professor at the University of Toronto, Department of Family and Community Medicine, the St. Michael's Hospital Division in Toronto. So those are kind of the other hats that I wear, other than as a clinician. A couple of other sort of housekeeping things just to mention. Brittany, is there anything else I should do before I start, or should I just launch straight in here? So,
no, I think you're good to just jump into it.
I'll just keep plowing along then. So no commercial support was received for this program, and there's no actual or apparent financial or ethical conflicts of interest in this course and in this presentation. If anybody would like access to not the video copy, although I suppose we might be able to put it on the same in the same shared file, but the PowerPoint presentation itself, as well as the worksheet that we're going to be working on, can both be found using either one of these two links. The Google Drive one's very long. I threw it into tiny URL, so that tiny URL link will also take you to the same Google Drive folder. So the main objectives with this talk are going to be specifically to talk about some of the science and the evidence base and the pharmacology behind the treatment of opioid use disorder. I've narrowed it down in that way for a couple of different reasons. One, it can be really hard to sort of talk about substance use disorders in general, and I think focusing it down a little bit more can sometimes be helpful. This is also probably one of the more stigmatized areas of treatment within substance use disorder. So I like to focus it on that as well. And I also just find that taking this illness out of the realm of sort of focusing on it from a moralistic perspective or from an enforcement perspective, and actually really sort of digging a little bit deeper into, hey, this is an actual, this is a disease, this is a chronic disease, a brain disease, and that there's actually really good scientific evidence for pharmacologic treatment with this, I really think sort of helps to demystify addiction medicine as an illness or substance use disorder as an illness. And yeah, and I think kind of going through the worksheet will hopefully help highlight some of those key points. This is particularly timely in Ontario at the moment to be talking about this. Opioid overdose deaths have hit an all-time high. It's on another slide as well in this presentation. but up over 60% since the start of COVID, opioid overdose deaths. And even before that, they've been climbing, as can be seen from the graph here, steadily for many, many years. So we are in the midst of the worst opioid epidemic Ontario has ever seen. And that has been exacerbated by the COVID pandemic. So this is a very, very timely presentation. I think it's also important to talk about funding, or frankly, in some cases, lack thereof in terms of addiction medicine care. So there have been numerous provincial and federal announcements in terms of new funding for opioid use disorder care. It's important to mention that that none of these new funding announcements have ever focused on providing additional funding to the physicians who are providing this care. And at least at the moment, roughly 85% of all addiction medicine, opioid agonist treatment care is being provided by community-based physicians in Ontario who basically invest their own life savings in terms of building clinics, building addiction medicine programs, and that funding has actually been reduced over the last 7 or 8 years. So while there have been new funding announcements, none of that has actually gone to where 80 to 85% of all the patients in Ontario are getting treated. And that's a shame, because when you look at where you can get the best return on investment in terms of treating folks with opioid use disorder care, these are kind of the various costs of different approaches for care. And as you can see, opioid agonist treatment such as methadone maintenance treatment or buprenorphine maintenance treatment, which is the other common form of opioid agonist treatment that we see in Ontario, they're really, really cheap compared with a lot of the other options that are out there. And so, the fact of the matter is, as taxpayers, we're gonna pay for one of these. We're gonna have to either pay to have patients incarcerated or have them on probation, or if they're untreated, it's going to cost society a lot of money because those folks cost the system a whole lot of money in terms of some of the activities that they're involved in terms of criminal activities, etc. So all of these other things are costing us, and if we could provide more funding for community-based opioid agonist care, that would definitely be a far better return on our investment than paying for a lot of these other things. And that was one study. There's numerous other ones. There's been numerous cost-effective analysis that have been done, and really this is by far the most cost-effective way of treating this illness. Not only is it cost effective, it's incredibly clinically effective as well. This is a study that was done looking at buprenorphine maintenance treatment. I'll just sort of explain kind of the study. It was published in Lancet in 2003. It was one of the first studies ever done in terms of looking at buprenorphine. What they did was they placed 20 people on buprenorphine, and 20 people were treated with detox. And the 20 people that were treated with detox, so they were not given buprenorphine treatment, as you can see, the people who are treated with detox, by day 50, 100% of them had relapsed, and by the end of the study, 4 of that group had died out of 20. So 20% of the group that were treated with detox actually died. In comparison, the group that were treated with buprenorphine maintenance, that's the red group here, at the end of a year, 365 days, 17 were still being retained in treatment, and none of them died. So this is a really small study, right? Like, it only had 40 subjects in total, 20 in each arm, and yet even a tiny, tiny study like that showed incredibly dramatic differences in terms of treating these patients with opioid agonist treatment versus trying to just detox them. This is a different medication, which is methadone instead of buprenorphine. They're both considered forms of opioid agonist treatment. This one uses a different way of measuring success. It's called numbers needed to treat. And let me explain what a number needed to treat is. Let's say there's a medication that you're using. And if you take that medication for 5 years for whatever the illness happens to be, if you take that medication out of 100 people, 1 person dies. And in the placebo group, the people who don't take medication, out of 100 people over 5 years, 2 people die. So that means that in that 5 years, you saved 1 person's life out of that 100. So that means the number needed to treat was 100. So in order to save 1 person's life, you have to treat for 5 years and you save 1 life. That's one way of doing it. Another way of doing it is called the risk ratio. And that's often the way drug companies like to report their stuff because it looks better. You could say, hey, you know what, by taking this medication, only half as many people died, right? Because in one group, 2 people died, in the other group, 1 person died. That looks really, really good. And that looks like, okay, you know what, everybody should be on this medication if, you know, like it saves half the people's lives. If you look at it from a number needed to treat perspective, the numbers don't necessarily look quite so so impressive. So there's a whole group of medications called statin medications or cholesterol-lowering medications. This is just a screenshot from an article published in the Journal of the American Medical Association in 2013. And it shows the numbers needed to treat. So basically, you can see that for all-cause mortality, you needed to treat 138 people for 5 years in order to prevent 1 death. Let's compare those sorts of numbers needed to treat, seen here, with the numbers needed to treat for methadone maintenance treatment. So the number of people you need to treat to reduce illicit opioid use is 2.9. HIV risk behavior, 4.6. Drug-related criminality, 1.4. You add all these together, you're getting close to a number needed to treat of about 1 or 2. In other words, just about every single patient that you treat benefits in some way, shape, or form from treatment. Comparing that to, say, cholesterol-lowering agents, those are really remarkably, there's very, very few medications we use that have numbers needed to treat that good. And yet, you know, I can tell you as a primary care doctor, there's absolutely no way you could graduate from medical school and not know a whole lot about how to use cholesterol-lowering agents. But it's very, very easy to graduate from medical school and residency and have no clinical experience with using opioid agonist treatment. Here's just some other stuff highlighting some of the unintended impacts of the COVID pandemic. So one of the things that happened during COVID was that funding for opioid agonist care went down significantly. So mental health and substance use funding decreased by roughly kind of 20 to 25% during the early COVID pandemic. So, you know, here we were facing the worst opioid crisis ever and also seeing sort of pretty significant reductions in funding. And that had an impact in terms of ability of patients to be maintained on care, because when funding goes down, programs are often forced to reduce hours, reduce staffing. And so what we saw was, you know, right here, sort of March 2020, you can see these numbers. This where it says right here, total K682, K683. That's some codes that are used in terms of physician billing to indicate patients who are on opioid agonist treatment. And you can see that pre-pandemic, that number was really, really consistent. It was, you know, pretty much within a few hundred patients of 49,000 month after month after month. And then take a look at what happened, like right at the beginning of the pandemic. That number dropped from 49,000 to around 42,000. We lost about 7,000 patients over the course of a month or two falling off opioid agonist treatment at the beginning of the pandemic. I'm not necessarily saying this is causation, but there's definitely a strong association here. We saw that at exactly the same time that funding went down and treatment retention went down, opioid overdose deaths went up by 60%. Okay, that's the cheerleading part of the talk done. I hope I've sort of demonstrated that there's a really good solid evidence base behind this, that we really do need to be funding this well, and that it really needs to be a priority for Ontario, and that unfortunately it hasn't been. We've actually seen reductions in funding, and that seems to be having significant impacts on morbidity and mortality. Okay, now we're going to get to some more skill-based stuff, and hopefully we can start making the rest of this presentation a little bit more interactive. So I've sort of finished with the didactic part, and now I'd like to really hopefully have a bit more of a team-based discussion here, and we're going to work through the worksheet. So again, that link that I provided at the beginning can provide access to that worksheet, so we can all sort of work through that together. So I'm hoping that my colleagues here on the call today can sort of help start chiming in here as we go through the worksheet. So this is just page 1 of the worksheet. What we're going to do for the next section is take a few minutes and work our way through some pharmacologic concepts that I think can help explain why these medications are as effective as they are, and how they're working, how they differ from the substances that patients may be taking on the street in terms of their opioid use, how these drugs differ from those other drugs, why they work, and kind of what the pharmacologic rationale is for this approach to treatment. So let's start with this then. What we're going to talk about are 2 kind of main pharmacologic characteristics. You know, when you're in med school, one of the things you first learn about are these 2 concepts, which is pharmacodynamics and pharmacokinetics. Another way of thinking about those terms is pharmacodynamics is what the drug does to the body, and pharmacokinetics is what the body does to the drug. And what we're going to see is that when we look at the opioids that patients buy on the street versus opioid agonist treatment, they have very, very different pharmacokinetic and pharmacodynamic properties. We're going to kind of work our way through here bit by bit. All right, so we're going to start with the pharmacodynamics, and I'm just going to move ahead here a couple of slides. By the way, this is the second sheet, so we can come back to this in a minute. This is the third sheet of the worksheet, and so let's start going through page 1 of the worksheet here. So right up at the top, it says, you know, in one column, heroin or, and then in the other one, it says methadone or. Really, for the heroin category, we could put down all sorts of other drugs. We could put down fentanyl, we could put down OxyContin, we could put down hydromorphone, we could put down morphine. And what we know is that if we take an experienced opioid user and we put an intravenous into one of their veins and we inject them with any one of these opioids, even an experienced opioid user wouldn't be able to say, oh yeah, you've just injected me with fentanyl. Oh yeah, you've just injected me with morphine. Oh yeah, you've just injected me with heroin. All of these drugs have remarkably similar effects on the brain and the rest of the body. So the way that they affect the body is very, very similar. We're going to go through that in a minute. So a lot of similar pharmacologic characteristics for all of the drugs that patients tend to purchase on the street. And you know, I've been doing this work now for roughly 20 years. I have seen the drug of choice on the street switch dramatically over those years. So for part of my career, the drug of choice was heroin. And then for part of my career, it was OxyContin. And then it switched back to heroin for a while, and now it's fentanyl. And the big reason for those changes is cost economics. So it's basically whichever one of these opioids is most readily available, supply and demand. So whatever's most readily available at the lowest cost is the one that the patients that I work with will access on the street. Comparing that now to the drugs that we use to treat opioid use disorder, such as methadone. Again, it says methadone, but there could be other ones that we could put in that category as well. So buprenorphine, which is another opioid agonist treatment drug, has remarkably similar properties to methadone, as does slow-release oral morphine or LAM. And here are some of those important pharmacologic characteristics of those two overall categories. So when we look at the drugs that people tend to buy on the street, like the fentanyl, the hydromorphone, the OxyContin, or the heroin, here's a couple of the pharmacologic characteristics that those ones have. Those drugs tend to have very, very high activity at the receptor and very, very low affinity at the receptor. Those are two very different characteristics of an opioid. So an opioid receptor has two pockets. One pocket that's involved in binding the molecule, and then the other part that's involved in activating the receptor when that molecule is attached. And so a particular molecule can do one of those things really, really well and one of them poorly. It could do both well. It could do neither one well. So every molecule can attach to those receptors in a slightly different way. In contrast, the opioid agonist treatment drugs have relatively low activity and a relatively high affinity. Now that we've sort of understood a few of those pharmacodynamic characteristics, I'd like to just sort of pose a couple of clinical scenarios to my colleagues that are here on the call, and see if we can sort of work through, knowing those first principles, what that might mean clinically. So let me propose a scenario here. Let's say that a patient has an opioid agonist treatment drug on board. Let's say they're taking buprenorphine. And they're having a bad day. And so this is a patient who is taking their buprenorphine treatment. They've had a really stressful day. They decide, you know what, like, that's it. I'm going to relapse today. So they go out and they buy their drug of choice. They're going to buy fentanyl. They're going to buy heroin. And they take that drug and they inject it. Given what we know about the affinity of these different drugs for the opioid receptor, which molecule is likely to win at the receptor? Which one is going to be binding to the receptor when you have both buprenorphine and heroin on board? Anyone?
Isn't it the mu receptors?
Yeah, so we're talking about, so there's different receptors. And yeah, I will also say, I'm oversimplifying a little bit here. There are different, there are a number of different opioid receptors. Clinically, the one we care about the most is the mu receptor. So when I'm talking about the activity and the affinity, I'm specifically referring to the mu receptor here, as opposed to some of the other opioid receptors. There's kappa, there's other ones as well. But in terms of that one, when we know that that buprenorphine has very, very high affinity at the receptor and heroin has relatively low, which one's gonna win at the receptor if these two drugs are competing for the opioid receptor?
I don't really know, but I'm gonna have to say heroin. No.
So it's got very, very high activity at the receptor.
Yeah.
But it's got low affinity. In other words, what that means is that if these two drugs are competing for the opioid receptor, it's actually the opioid agonist treatment drug that wins at that receptor. And that it's not intuitively obvious, right? You think, oh, you know what? These street drugs, they're really, really strong. That must mean that they not only strongly activate the receptor, they strongly bind to the receptor. They don't. They weakly bind to the receptor, but if there's no other molecules around, of course, that's the one that's going to bind to the receptor. But if that molecule has to compete with other molecules for the receptor, other drugs may actually have higher affinity at the receptor. They may bind more to that receptor. They just don't simply activate that receptor very much. It's an important concept, and it helps very much explain why these treatments are so effective. So that means two things clinically. It means that when you've got an opioid agonist treatment drug on board, and you go out and you buy your drug of choice, you buy your heroin, you buy your fentanyl, and you use it, you don't get as high. It becomes less reinforcing. Secondly, it also means that patients who are on opioid agonist treatment are at lower risk, not higher risk for an overdose. And again, that doesn't necessarily seem clinically obvious. Oh, you know what? I've already got them on an opioid. I've got them on methadone. I've got them on buprenorphine. Now they're taking another opioid. Surely they must be higher risk for overdose because now they've got two opioids on board. No, that's not true because they're competing for the same receptor. I will also say for most of the drugs that I use as a family doctor, I don't know nearly this much about their pharmacology. And the reason I don't is because it's not clinically relevant to me. I don't need to know the pharmacodynamics and the pharmacokinetics of a cholesterol-lowering agent because it doesn't impact my clinical decisions. With opioid agonist treatment, understanding these concepts is really, really helpful for me, both in terms of making clinical decisions and also understanding why they work so well. Does anybody have any questions on the pharmacodynamic stuff before we move on to the pharmacokinetic stuff? I'm actually happy we got the answer wrong on that one because, again, the fact is it is non-intuitive. And that our guesses on these things are actually often the opposite of the way the drugs work. And so when we understand that, it becomes a lot easier to make those, to understand why they work and to also make appropriate clinical decisions. Okay. So let's keep going and let's hope we get more wrong because that way we'll be even better at figuring this stuff out. Now we're going to move on to some of the pharmacokinetic characteristics. And remember, we talked about pharmacodynamics. That's what the drug does to the body. Now we're going to move on to what the body does to the drug. And again, when you are in med school, you learn to sort of answer if you get asked by your supervisor, talk about the pharmacokinetic characteristics of drug X. You usually start by saying the four important pharmacokinetic characteristics to understand are absorption, distribution, metabolism, and elimination. And then you would go through those one at a time. So we're going to start with absorption, which is how does the drug actually get into the body? Interestingly, when you look at the way individuals with opioid use disorder tend to move through their choices of how they're going to use that drug, it follows a remarkably similar pattern from patient to patient to patient, despite the fact that most of them have never taken a pharmacology course, yet somehow they all use the drug in very, very similar ways. And here are a number of the ways, here are a number of the things that we see as similar from patient to patient to patient. The vast majority start with oral use. In fact, the evidence is 80% or more of folks with opioid use disorder, their first experience with an opioid is through a prescription from a doctor. That's important, right? So there still is this misconception that this is a group of individuals who started using these drugs recreationally, and that they're not like other patients, not like other members of society. No, in fact, this is an illness that runs the gamut. The oldest patient that I've started on opioid agonist treatment was in her 90s. The youngest was in his teens. And so crosses the spectrum in terms of gender, in terms of age, in terms of socioeconomics, and the vast majority of people who end up with opioid use disorder start with a prescription for an oral opioid. And then as time goes by, so you start chewing it, you start snorting it, they start smoking it, and then they inject it. And there's a reason why things drift in that way. When you move along that spectrum of different ways of using the drug, each and every one of those has a faster onset of action. In other words, when you are looking for that effect, either to relieve your withdrawal or to experience the reinforcing effect, each one of those means it gets into your bloodstream more quickly. It's one thing. It means more of the molecules hit the brain all at once, which makes the reinforcing effect higher. So if the molecules are drifting in slowly, 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 you're going to get a relatively flat concentration of that drug. Versus when you snort it, inject it, smoke it, you're getting a whole bunch more of the molecules all hit the brain all at once. That means it's going to have a stronger impact. And then the final thing is, more of the molecules get into the bloodstream. So, so when you swallow a drug, not all of it gets into your bloodstream. Some of it is going to come out the other end. Some of it's going to something called first pass effect, which basically means the drug has to go from your intestines where it's being absorbed through the liver before it hits the brain. And your liver can metabolize that drug. So that's called a first pass effect. So, so all of those things reduce the number of molecules that actually hit the brain. Injecting a drug, you bypass a lot of those. And smoking the same thing. When you smoke a drug, you're actually bypassing the liver as well. So you're just going from the lungs pretty much straight to the brain. I think we've got time. I'm going to do one more sort of like little thought experiment before we sort of move on to the methadone side. I'm going to switch gears here for a second. I know we said we're mostly going to talk about opioid agonist treatment. I'm going to talk for a couple minutes here just about nicotine and how some of this kind of interesting pharmacokinetics is kind of, again, clinically relevant. If you're an evil scientist and you want to create a perfect drug of abuse, make sure you can smoke it. Because for the folks here who have taken any sort of like anatomy stuff, if you think about what happens when you inject a drug, you're injecting it into your vein. So that's the venous side of your circulation. So then it goes from your vein and then it gets pumped back to the heart, to the right side of the heart. It gets pumped through the lungs to the left side of the heart, and then it goes to the brain. When you smoke a drug, you bypass the whole venous side of your circulation. It just goes lung, brain. So it's even faster than injecting a drug. The reason our patients tend to switch eventually from smoking to injecting is not because it's a better high, it's because you get more of the molecules hitting your brain. So if you have to buy these drugs on the street, they're very, very expensive. An average opioid user will report spending several $100s a day to support their habit. So if they can inject a drug and get more of the molecules to their brain, they'll do that. But the way to get the drug into the brain the fastest is to inhale it. And I sort of started this whole thing by joking about, you know, the evil scientist thing. There actually are, there truly was in the whole tobacco industry, there were evil scientists whose job it was, they were hired by big tobacco to figure out ways to improve the nicotine delivery system. And I'm just going to mention one, which is filters. And Google it afterwards. You can. There's an ad, and I should have included it. There was an ad. I can't remember which cigarette company it was. It has a doctor in a white lab coat. This is soon after they introduced filters, and it says whichever cigarette that was helps filter the smoke. And it's got a doctor actually in the ad itself. And so this is the way that it was marketed, is okay, filters smoke. They sort of hinted helps filter carcinogens. That was not why filters were introduced. The reason filters were put on cigarettes is because it makes you suck harder. Here's what sucking harder does, okay? So when you're sucking on a cigarette, you're causing what's called negative intrathoracic pressure. So when you're sucking on that, you're not only sucking on the air coming in, it's like pulling back on a syringe. What you're also doing is when you're sucking on that cigarette, you're also sucking blood back from your lungs into your lungs. You're creating a negative pressure. When your lungs are expanding, it's sucking air in, but it's also sucking blood back from your limbs into your lungs. So it actually increases the amount of nicotine that hits the lungs. That's why Big Tobacco introduced this. And there was a number of whistleblowers from within the tobacco industry, scientists who eventually had a change of heart, who disclosed, this was in the era when the tobacco companies were saying, oh, goodness, if only we'd known nicotine was addictive, we would have done so much differently. No, there was really good evidence that they absolutely knew it was addictive, and they were hiring scientists to try and come up with new and better ways to make nicotine, improve the nicotine delivery system to get people more addicted to cigarettes. So I hope that sort of helps highlight how important some of these pharmacokinetic qualities can be in terms of like addiction and addiction medicine. Bit of an aside, but I thought it was interesting. Let's compare that now with our opioid agonist treatment medications. We'll talk here about sort of 3 different ones. So let's start with methadone. We do something really odd with methadone. So methadone in its natural form is a powder. We could make it into pills. We could put it in syringes and give it to people to inject. We don't. We mix it with 100 milliliters of orange juice per bottle. We give patients 1 bottle each day. So take this, they either drink it at pharmacy or they take it home. Any thoughts? And I'm not necessarily expecting anybody to have a guess, but why would we mix it with orange juice? Lauren, go ahead.
It's what my first thought was, it is less, I don't want to say embarrassing, but it makes the patient feel a little bit more secure, and that other people aren't judging them for what the drugs that they are taking to seek treatment for their disease. So it makes them feel a little bit less like they're taking treatment, but more that they're just drinking orange juice. And it's more, it's less taboo than taking a pill.
That might be, but there's also an important pharmacologic reason why we do it. So, any thoughts as to what the pharmacologic reason behind why we would want to mix it with orange juice? Rosalie?
Well, it's an odorless, colorless liquid. So it kind of like, it tastes better when we do it a little bit. And the orange juice masks, it does taste a little bit bitter, so it's not completely tasteless. So it prevents the patient from accidentally overdosing on such a strong opioid. So that, because if you can't taste something for the most part, but it's a strong drug, then it prevents the patient from accidentally overdosing.
So it does. So definitely, methadone can have a slightly bitter taste. And so that is one of the reasons why mixing it can also be helpful. But there's another one as well. When you take a look at, does anybody know what type of, when patients go to like a needle exchange to get their needles to inject their heroin, has anybody sort of seen what those needles look like? They're tiny. They're actually the smallest needles, right? So the needles that patients use for injecting heroin and fentanyl are the really, really small needles. You don't want to try and inject a whole lot of fluid into a small vein. It's painful, it doesn't work very well. So what does mixing a small amount of methadone powder with a whole lot of orange juice prevent?
Dehydration.
That's one thing. It also prevents you from being able to inject it. Remember what we talked about. One of the reasons why heroin and these other molecules are so reinforcing is because all of them are hitting the brain all at once. Okay? If you were to inject methadone, you'd have all those molecules of methadone hitting the brain all at once. That's going to increase your risk of overdose, and it's also going to make it somewhat more reinforcing, right? So if you get a big spike of a whole bunch of opioid molecules hitting your brain at once, that has a different impact than if they're hitting your brain in dribs and drabs. Does that make sense?
So kind of like eating on an empty stomach, or drinking alcohol on an empty stomach a bit?
Correct, yeah. So basically what drinking on an empty stomach does is your stomach, is your intestines are really, really ready at that point to absorb everything really, really quickly. Like the whole intestinal system is ready and will be absorbing exactly what's come in. It's not going to be tasked with absorbing the alcohol and absorbing food and absorbing all these other things. So basically what that means is the whole bunch more of that alcohol hits your brain simultaneously. Okay, so what this is doing is it's slowing down how quickly those molecules hit the brain. So you're getting a steady level rather than a spike. So that's what we do to prevent patients from injecting methadone. We do something really odd with buprenorphine as well. Buprenorphine comes under the trade name Suboxone, and it actually contains two drugs. It's got buprenorphine, and it's got another one called naloxone. Has anybody here heard of naloxone? Somebody tell me what naloxone is.
It's an opioid antagonist.
Correct. Okay. And now you guys know what understand what an opioid antagonist is, right? So going back to what we talked about before, going back to the pharmacodynamic properties, here's what naloxone is. It's a drug, it's a molecule that is perfectly suited at binding to the affinity pocket and is terrible at binding to the activity pocket. It's a competitive antagonist. So what that means is that if you have naloxone on board, also called Narcan, and if you've got heroin or fentanyl on board, and they're both competing for the opioid receptor, which one wins? Which one wins out of Narcan or heroin? Can somebody take a guess on that one?
The naloxone wins.
Exactly. It pushes the other one off the receptor. They're both competing for the same receptor, but Narcan, naloxone, does that way, way better. And we put some naloxone in with the buprenorphine, and I'll explain why. The way that patients take a Suboxone tablet, which contains buprenorphine and naloxone, is they place it under their tongue. It's called sublingual absorption. Buprenorphine is well absorbed sublingually. Naloxone is not absorbed at all sublingually. So if they take it the way that they are told to take it, which is place it under your tongue, they get the drug they need into their bloodstream, which is the buprenorphine component. And the other one, the naloxone, which they don't need, they don't want, because it's going to make them go into withdrawal if it gets into their bloodstream, does not get absorbed. But what happens if they crush it and inject it? both drugs get into their bloodstream.
Yeah. I wanted to say, like, I saw what you wrote tamper resistant, and now like it's making a little bit more sense that they're, because like they're just being safe. They're just being on the safer side.
Right. So what we're doing is we know that this is a patient population who would be tempted. You know, there are a lot of our patients are experienced drug users. They don't have that same aversion to experimenting with an injectable drug. So we want to try and keep our patients safe. So these mixing methadone with orange juice reduces the risk that a patient will try and inject it rather than taking it orally, which is the way it's intended. Mixing buprenorphine with naloxone and telling patients to place it under their tongue reduces the risk that they may try and crush and inject that drug. And remember, not only that changes the pharmacologic characteristics, it makes the drug spike rather than giving you a flat level. What we want is to give them a flat level. That's why this works. We want to give them enough drug to keep them out of withdrawal, but not so much that they're going to overdose. And one of the best ways to do that is to make sure that the drug is slowly absorbed. Okay. What we do with slow release oral morphine, also called SROM, or the brand name drug that we most often use for this is called Cadian, which is morphine sulfate in pellets, tiny little pellets, and each one of those little pellets has a micro bead around it. So like a little packaging around each little granule. And again, because it's a capsule filled with like hundreds of these tiny little beads, what we do is we get the pharmacist to break it open and sprinkle it on applesauce. Again, that's pretty hard to start injecting, right? So, and then the other piece is, again, this is a bit more of a clinical thing, is early on in a treatment program, our patients are actually going to the pharmacy every day for witness dosing. So they also don't have the ability to take multiple days of doses at once if they are tempted to try and achieve a more euphoric effect by just doubling their dose. So if we make them go to the pharmacy each day for their doses when they're in early recovery until they've had a chance to stabilize, that can also be helpful in terms of reducing the risk of overdose or other unintended consequences. Does that make sense in terms of how the absorption of the street drugs is very, very different from the treatment drugs? All right, let's keep moving. So here's just a few other things. Yeah, I don't think there's anything here I have to talk about. Okay, so we talked about absorption. Now we're going to talk about was that distribution? Yeah, okay. Distribution, I think I just skipped over that one, maybe in the presentation. I think the key thing in terms of distribution is all these drugs are crossing the blood-brain barrier and they're going into the brain. That's where they're distributing to. Metabolism, you know, as I talked about, like when we look at somebody who is using opioids on a regular basis, even if they've never taken a pharmacology course, they all use it in really, really remarkably similar ways. They all take it about every 4 to 6 hours. That's true if they're taking fentanyl, that's true if they're taking heroin, it's true if they're taking OxyContin, and there's a reason for that, and it's called the half-life. What half-life means is it's the amount of time it takes for half of a drug to be metabolized and eliminated from the body. And every drug has its own half-life. The half-life of the street opioids is remarkably similar from drug to drug to drug to drug. It's about 4 to 6 hours. And lo and behold, by the time about half that drug is gone, if you're somebody who is physically dependent on an opioid, you are not going to be feeling good anymore. You're going to start having nausea, you're going to start having vomiting, you're going to start having diarrhea, you're going to start having shaking. Your brain is not going to be happy, you're going to be having severe cravings. And that happens 4 to 6 hours after you take the drug. So by that point, you're going to really be ready for your next dose. So that's the metabolism of street opioids. let's compare that to the half-life of the opioid agonist treatment drugs that we use. So I've listed them there. So half-life for methadone is 24 to 36 hours. Half-life for LAM is about 48 hours, and the half-life for buprenorphine is about 72 hours. So what that means is that these drugs give you a very, very steady level all day long. Okay? If you use heroin just before you go to sleep, it's got a half-life of 4 hours. You sleep for 8. How much of it is still left in your body when you wake up the next morning? Go ahead, Lauren.
I was just going back to like the different modes of absorption from the methadone and the buprenorphine. I was wondering if the half-life changes depending on the mode of, like, depending on how they take it. So does the, like, in methadone's case or buprenorphine's case, if it's injected, does the half-life change rather than if it's taken with orange juice?
A little bit, yeah. So
Okay.
it would change in a few different ways. So one thing is that the more quickly a drug gets absorbed, the more quickly your liver and your kidneys can start eliminating, right?
Yeah.
So yes, that does make a difference. But there's also, so in other words, when you take a look at how quickly a drug peaks, when you're swallowing an opioid, like a morphine tablet, not one of the slow release oral morphines with microbeads, but if you just take like a standard morphine tablet, if you swallow it, it will tend to peak about half an hour to 40 minutes after you take that drug. If you were to measure the concentration of morphine in the bloodstream, that's when it's going to be the highest. When you inject a drug, the highest concentration is within a minute or two of when you've injected it, right?
Yeah.
So that would push the half-life back by roughly half an hour or so. But really, most of what determines a half-life is not how you absorb it, it's actually how it's metabolized and eliminated. So and all these drugs, it's pretty similar. So yeah, so the half-life is going to be a little bit shorter when you inject it, but most of what's going to determine the half-life is how effective your kidneys and your liver are at metabolizing and eliminating it. Does that make sense?
Yeah, it does make sense. Thank you.
Right. Okay. Yeah, so I think kind of key thing here is, oh yeah, we were talking about my clinical scenario of, okay, if a drug has a half-life of 4 hours and you sleep for 8, and you've injected your heroin user, you've injected heroin just before you've gone to bed, you go to bed, how much is going to be left 8 hours later? Just doing the math.
Probably like a very little bit or none.
Yeah. So after 4 hours, 50% is gone, right? So let's say we started with, just throw a number out there, 100 nanograms per milliliter. I don't know if that's even like an appropriate number for what the concentration of heroin would be in your bloodstream, you know, after you've injected it. So it's going to peak about 10 minutes later, as I said, so 5 to 10 minutes later. So 5 to 10 minutes after you've injected it, you've got 100 nanograms per milliliter. A half-life of 4 hours means that 4 hours later, if you were to measure the serum concentration of heroin at that point, it's going to be half of that. So it's going to be 50. 4 hours after that, half of that's going to be gone. It's going to be 25. 4 hours after that, half of the 25 is going to be gone. It's going to be 12.5. 4 hours after that, it's going to be 6. 4 after that, 3, et cetera, et cetera. So basically, by the time they wake up in the morning, 75% is already gone from their system. Is that somebody who's going to wake up like ready to greet the day and just feeling like chipper and all great? Or are they going to be feeling like death warmed over?
not going to be feeling super good.
They're not going to be feeling good. Okay, now let's compare that to somebody who's on buprenorphine. Okay? Buprenorphine has a half-life of 72 hours. It's got a half-life of 3 days. Okay? What that means is that if you were to start again with a number like 100 nanograms per milliliter, it's going to take you 3 days without taking your buprenorphine to reach half of that, to reach 50 nanograms per milliliter. In other words, if it takes 3 days to get there, to go from 100 to 50, you work that out, that's going to be roughly about 18 nanograms per milliliter per day to get you to half of that gone in 3 days, right? So they start with 100 at the beginning of the day. By the next day, when they're taking their next dose, it's only gone from 100 down to like 82. Not much has left their body. They're going to wake up the next morning still feeling okay. Does that make sense as an important reason why these medications can be effective? Great. So one of the other kind of concepts you learn about, we're talking about elimination here. So how long does it take to kind of get rid of most of the drug in your body? So for a drug like heroin or fentanyl, it takes about 3 to 5 days for just about all of it to be gone for the body. Whereas for a drug like methadone or buprenorphine, it really takes closer to a week, 10 days for you to eliminate most of that drug. So you can get these sort of steady level effects where every day you've got a steady level of this drug, enough to keep you out of withdrawal, but not enough to make you intoxicated. So that's the absorption, distribution, metabolism, and elimination, comparing the street drugs with the opioid agonist treatment drugs. Okay, that's page 1 of our worksheet. I want us to go through some other characteristics here. Let's start with the kind of the graphic here on the right, where it's showing, 2 molecules. And so here in the blue, those are sort of my graphic representations of a heroin and a methadone molecule, or a methadone and a heroin molecule. I want you to guess which is which. And this up above is my graphic representation of an opioid receptor with the 2 pockets. One pocket of the receptor, it's like a lock and a key. So one pocket of that receptor is the component of the receptor that's involved in activating the receptor, and then the other part is the part that's involved in binding the molecule. So which one of these, the top one, which one looks like it would bind better in the activity receptor, and which one it looks better in the affinity of the receptor? But let's go with the top one. Does the top one look like it binds better in the activity or the affinity receptor?
The activity.
The activity, right? The bottom one looks like it would fit really, really well in the affinity part of the receptor. So if you take a look, you can see that this one would be more kind of in keeping with a high activity, low affinity molecule like fentanyl, like heroin, one of those, whereas the bottom one is much more like the treatment molecules. Does that make sense? This is what we were talking about before in terms of if you were to sort of look at a day in the life of somebody who's using heroin versus a day in the life of somebody who's on opioid agonist treatment. You can see here, and so when we take a look at serum levels, so a patient is physically dependent on an opioid, if the serum level is too low, they're going to be in withdrawal. If they get the right amount of that molecule, they're going to feel okay. If they get too much, they're going to be intoxicated. Even more, they're going to overdose, and even more than that, they're going to die. Right? So this is kind of a day in the life of somebody who is a heroin user. So as we talked about, they're going to wake up in withdrawal in the morning. They're going to take their drug. It's going to spike really, really quickly, drift down over about 4 to 6 hours. They're going to take their next dose just as they're starting to really start experiencing a lot of withdrawal. It's going to go up again. It's going to drop back down, go up again, drop back down. And you can see over the course of a day, it's basically going up and down by about 50% over the course of each day. In contrast, when we give somebody a long-acting drug, it's going to get into the body more slowly, as we talked about, because it's going to be absorbed more slowly. It's going to slowly drift down over the course of the day. Does that kind of make sense? Good. Any questions about that? Great. Here's another way of looking at those same ideas, except instead of time, we're going to look at the percentage of the receptors in the brain that are saturated with particular drugs, and then looking at the response at the opioid receptor when we look at different molecules. Okay. So in terms of response, again, if you if there's very little, if you're opioid dependent, you don't have a lot of opioid response from that molecule, you're going to be in withdrawal, then you're going to feel normal, then you're going to be intoxicated, then you're going to overdose, and then you're going to die. Okay, so with a very, very high activity molecule like heroin, you don't need to saturate a lot of the receptors. You don't need a lot of that molecule attached to a lot of receptors to go from being in withdrawal to feeling normal to being intoxicated to overdosing and dying. Like your window between the amount of the drug that's going to make you feel okay and the amount that's going to kill you is not very big. So it's easy to overdose accidentally, etc., particularly since you're not going to be buying a standardized supply and where you can be sure that exactly what you're buying is the same as exactly what you bought yesterday. A drug like methadone, if you take enough of it, absolutely, you can still overdose and you can still die. It's just going to take more of the receptors to be saturated in order for that to happen. Buprenorphine has activity at the opioid receptor, but that activity is so weak that even if you get up to like 85 or 90% opioid receptor saturation, guess what? You need that much just to start getting, you need like 50 or 60% just to start feeling normal, and you need like 85 or 90% to get up to kind of the upper end of feeling normal. And even if you get 100% opioid receptor saturation, it's not a strong enough, it doesn't have enough activity to the opioid receptor to actually cause you to become intoxicated, overdose, or die. So it's really, really difficult for somebody who's using buprenorphine, even if they were to inject it, even if they were to take 3 or 4 days all at once, it's very, very difficult for them to actually cause overdose or death. And then naloxone, which is the drug that we talked about, which is a competitive antagonist. More and more receptors have naloxone attached. You know, it's going to push more and more of the other stuff off, and they're actually going to go from, you know, being dead or near dead to actually intoxicated to feeling normal to actually going into withdrawal. Does that make sense? Great. That is the formal part of the presentation. So I'm open for any questions or answers or anything else we'd like to do with our remaining time.
Thank you so much. That was a really amazing presentation. I think that I can speak for all of us here and probably everybody watching it later that like we learned a lot from this. So thank you so much for like coming to talk to us and sharing your knowledge with us. I did have one question that I wanted to ask you, and that would be like, how do you think the medical school curriculum could be adjusted to better prepare physicians to treat patients with substance use disorders?
Thanks. Yeah, that actually is one of my passions. As I mentioned, one of my qualifications is that I am on faculty at the University of Toronto. This was very poorly taught for me in my medical school curriculum. I graduated from medical school knowing virtually nothing about addiction medicine. It was only once I started doing more clinical practice that I came to realize that this was, you know, an element where my education had really failed me. And I definitely am continuing to see students who come through our electives and who are reporting things have not changed, that the education that we get is still subpar in terms of this. And And there's, I think, a number of reasons for that. One is it's often, if it's offered at all within the curriculum, it's presented as being outside of mainstream care. And it's not taught within standard components of the curriculum. You know, when you're taking your pharmacology courses, they'll teach you about cholesterol lung agents. They'll use that as their example drug, but they don't tend to use drugs like opioid agonist treatment. One of my advocacy efforts, which unfortunately has still been falling on deaf ears, is my recommendation is, look, I know, you know, I was a medical student, I still work with medical students and residents. I know how busy the curriculum is. I know that it's really, really tough to add in brand new modules to say, okay, you know what, because every time you do that, there's something else you have to cut out. My argument has been, as I said right at the beginning of this presentation, there is no other drug that I use as a family doctor, and we use one of the widest variety of drugs of any group, because we're generalists. We treat patients with diabetes, we treat patients with multiple sclerosis, we treat patients with rheumatoid arthritis. We use a whole bunch of different medications, and there is no drug that I use where I know the pharmacology as well as I do opioid agonist treatment, because it's not as clinically relevant. There is no set of drugs where understanding the pharmacology is more relevant than this is. So my argument has always been, why aren't we teaching these important pharmacologic characteristics using a drug that illustrates them better than anything else? Let's start using opioid agonist treatment in our curriculum as one of the drugs that we learn about to understand concepts like pharmacodynamics, pharmacokinetics. Why are we choosing a drug that's less clinically relevant when we have these drugs available? And I think that serves several purposes. It reinforces that there really is a sound evidence base and a sound pharmacologic basis for using these drugs, and it takes it out of that moral realm. You know, often addiction and addiction treatment is viewed through the lens of enforcement, through the lens of it being a moral failing, and I think this takes it out of that, frankly, very inappropriate way of viewing this this condition, and says this is a disease. It's got a basis in neurochemistry, and the treatment drugs also have a basis in neurochemistry. So let's learn about that. Absolutely. Do we still need to look at things like social determinants of health and those other elements of why it is that that treatment isn't as effective as it could be? Absolutely, that's still important, and I think that should still be taught. But at least in terms of a lot of the stuff that we've talked about today, my argument is, hey, you know what? Let's start teaching this within core curriculum, using treatment for addiction medicine as a way of learning about important pharmacologic concepts, etc., that medical students and residents are going to have to learn anyway, and this will reinforce it better than anything else. So, but nobody's listening.
That's great. Thank you. I think Lauren also has a question.
Yeah, thank you. That was an amazing answer. But how do you create these open conversations about substance use? And what are some points that you can use to help educate people and open their minds about destigmatizing substance use disorders?
There's some interesting studies that have been done. One of them that I really like is quite an elegant study, and this was actually done, I think, by some family medicine residents. And so here's what they did. They took a mock clinical scenario of a patient with a substance use disorder. and in one, and the facts of the clinical scenario stayed exactly the same. But what they did was, in one scenario, they used pejorative language, street lingo, etc., to describe that clinical scenario. And then in the other one, they used non-stigmatizing, non-judgmental language to describe exactly the same clinical scenario. So in one scenario, it's like, a junkie walks into the emergency department. They report that they're, buying H on the street. They're what other terms like they use? They were slamming it like 4 times a day. They're spending most of their day pinned, and now they're here in the clinic, and then so that's the end of the scenario. And then there's a bunch of questions like, what would you do in terms of treatment? How long would you expect this patient to be in the emergency department for? What do you figure are their chances of returning, etc.? And then in the second scenario, they described exactly the same clinical situation, but used non-pejorative language. So they said, the other things it would say would be things in the other one would be like, their urine test was dirty for heroin and cocaine, or for speed and for H, or whatever it was. And then in the second scenario, it's like, an individual with substance use disorder presents to your emergency department and self-reports that they are using cocaine and heroin via injection, and they're looking for help. What would you do in terms of treating them? And in that, and then those same series of questions afterwards, and the answers were remarkably different. So, so we know that the way we teach this and the way that the lens with which we view this has clinical implications in terms of how it is that we manage these patients. So I think one of the things that is really, really important in terms of changing the language is the language that we use and the way that we view this matters. So I think viewing this not as a moral failing, but viewing this as a biopsychosocial illness is very, very helpful in terms of allowing us to provide more effective treatment. That the evidence is clear that when we change the lens with which we view this, it actually changes our ability to provide effective treatment. And our patients are smart, and they know that. They know that that many elements of the healthcare system do not treat them well. And we don't want that to be the case when they come into one of our programs. So we want to make really, really sure that they understand that we respect them as individuals, that we understand that this is an illness, that and that we're there to treat them in a respectful and dignified manner.
Thank you.
Great. And then Rosalie, if you have one last question maybe that you want to ask, go ahead.
I just want to say thank you for coming, first of all. I really enjoyed the presentation. I did my first degree at Carleton in law and legal studies. So I came from the background of learning first about the demoralization of people with addiction. So I know all about that first before I came into sciences, and I'm intending to go to medical school. So I come with that background first, intimately. How do you suggest would be a applicable way to bring that knowledge as someone with the legal background, albeit at the undergrad level, not the actual professional legal level? How would you say that I would do that in the best way possible going into, if I get in, it would be a good way for me to try and bring that knowledge into the medical student system? How would, like from the inside out, kind of like a Trojan horse scenario, I guess. How would you think I would be able to do that functionally, from your perspective?
I think at the beginning of the presentation, I mentioned some of those slides pointing at how not only are incarceration enforcement approaches way more expensive, they're not as effective, right? And so I think talking about some of those aspects, like it doesn't matter where you fall on the political spectrum. The bottom line is, like, even if you're like super conservative, like a war on drugs approach isn't going to work. You're gonna throw your money away, and it doesn't work. So let's try and just put that element of things aside and actually take a look at, just practically speaking, what actually works, because there's been lots and lots of studies that have looked at that, and it's pretty clear what works and what doesn't. So let's stop trying to look at things through that moral lens and start looking at things through the lens of practicality and what actually works. And I found that seems to be, when I'm talking to people who might have a different perspective on this illness than mine, just saying like, okay, you know what, judge this however you want, but the bottom line is, if you throw these people in jail and you don't address any of these other things, you know what's going to happen? They're going to leave jail and they're going to be right back doing all those things that you complained about in the first place. So throwing people in jail for this does not solve the issue. So we've got to look at approaches that actually do work.
Yeah, recidivism is a huge problem, and the advocacy and a united front is definitely a better way to go.
Yeah. So evidence base is that if you just try and treat somebody, as we said, we saw from that Lancet study, just try and treating people by saying, you must stop, just say no. 95% relapse rate or more, and 4 people dead in a year out of 20, right? So 20% dead. Really, that's the approach that we want to take as a society. Just say no, right? So it doesn't work, right? So I think that helps. One sort of little thought exercise that I've done sometimes, when often, particularly when I come in, I have family members saying like, can't we just detox this? Can't we just there's got to be a quick and easy solution here. And it can be tough, right? For somebody who's never experienced an addiction, to understand just what is going on in terms of the brain. And one little one where I've started sometimes seeing like a bit of a light bulb go off in people's brains who are sort of struggling to understand it is what I talk about is, okay, we're going to talk about this being a brain illness and where the illness is located in the brain. The part of your brain that gets changed with this is the brainstem. It's the primitive part of the brain that's involved in really important survival functions. It's not the smart part of your brain. It's the brainstem that gets altered by your use of these substances. It's the same part of your brain that does other important survival things like breathing. So just as a thought experiment, let's take sort of 2 other things that your brain does, like breathing, and it's also it's the part of your brain that's also involved in bowel and bladder function as well. So imagine, we'll start with the bladder one. So you're stuck on the 401. It's like bumper to bumper traffic, and you desperately need to pee. Your bladder is bursting. That's your brainstem that's saying that. The smart part of your brain, the executive function part of your brain, can say, now is not a good time to pee. Like, I'm sitting here in a car, there's nowhere for me to pee. Your brainstem doesn't care. And as the minutes and the hours drift by, your brainstem cares less and less what the smart part of your brain is saying. It's just saying, It's not my job to fix this. It's my job to tell you, you gotta fix it. You gotta fix it now. And just because you're smarter and just because you have a bigger pocketbook doesn't mean you're going to be able to withstand what your brainstem is saying better than somebody else. Now let's take breathing. If you want to go on Google right now and say, how long can you hold your breath for before it's going to cause any brain damage? It's going to say something like 2 or 3 minutes. Okay, so now we all know that intellectually. We just read that on Google. We can hold our breath for 2 or 3 minutes and not cause any brain damage. Okay, so I challenge all of you to now hold your breath for 3 minutes because you know that. Your smart part of your brain might know that, but that's not the part of your brain that controls breathing. It's your brainstem that controls your breathing. And after 45, 50, maybe 60 seconds roll by, your brainstem's going to say, smart part of your brain, don't care what you've got to say. You're listening to me now. Your brainstem's perfectly happy to leave, the executive part of your brain, your frontal cortex, in charge until it isn't. And when it says, nope, you're not in charge anymore, your brain becomes a slave to your brainstem. And that makes sense, right? The brainstem's survival, right? That's the part of your brain that is involved in this. So the cravings that somebody has when they're when they have opioid use disorder would be similar to the sort of cravings you'd have to breathe after a minute had gone by. Now imagine that day after day, week after week, month after month, where you're just white knuckling it all the time, where your brainstem's clamoring for that next drug, the way that your brain would be clamoring to take a breath after a minute or two. So that can sometimes, and again, we wouldn't necessarily say, okay, if we had to take a room full of people, which one's going to be able to hold their breath the longest? We're not going to say, oh, you know what? It's the one who went to church every day on Sunday. I'm sorry, everyone. I'm just going to have to take. Hi, I guess you haven't looked at my calendar. I'm giving a presentation to a whole group of people right now. Okay, all right. Thanks. I'll talk to you. Bye. Any other questions?
Thank you. Just being mindful of time, I just wanted to end things kind of on a really light note, and I just wanted to ask you, what is your favorite part about your job?
It really is the patients that I work with. It's one of the things that the medical students and residents that come in and work with us, it's probably the most unanimous comment I get from them is that they are remarkably surprised by just what a great bunch of patients that we've got in our program. That they it's a group that have often been mistreated by many elements of the healthcare system, and so when they finally find a place where they're treated with some dignity and respect, they frankly shouldn't be as grateful as they are, but they are incredibly grateful to just finally have a place where they feel welcomed and respected, and where they're treated with some dignity and respect. And yeah, it's a great feeling. And there's also the fact that I kind of gave some of those numbers for cholesterol lowering agents, so I could treat 100 patients for 5 years. And it's a blip in the radar that maybe I helped somebody out when I treat somebody with a cholesterol lowering agent. When I do this, it's really satisfying, because in the matter of a couple of weeks, you have somebody come back and they say, yeah, you know what, a month ago, I was spending every last cent on my drugs. I wasn't able to pay my rent. I was having all these problems, and now my life is being turned around, and it's happened in a relatively short period of time. And that's really gratifying. So I think, yeah, I would say it's that, at this point in my career, I'm doing 95% addiction medicine. with some Hep C. That's kind of my other big area. But even when I was doing more sort of general primary care, when I would look at my my appointments for the day, when it was one of my addiction medicine patients coming through the door, it wasn't, oh, this one's going to be difficult. It's going to be, puts a smile on my face. It's like, you know what, this is going to be a really, really good clinical patient encounter, because this is such a great group of patients to work with.
Amazing. Thank you so much. Well, I know you're like super busy and you definitely have a lot to get to today. So we just wanted to say like, thank you so much again for coming to speak with us. And like, we really appreciate you taking the time to educate us more on this topic.
It's my pleasure. Thank you so much. Take care, everyone.